Aurora Brown and intersectional psychology acknowledge the traditional owners and custodians of country throughout South Africa and their connections to land, water, and community. We pay our respects to their elders past and present, and extend that respect to all Indigenous people listening today. This episode is for educational purposes only and is not intended to be a substitute for professional health advice, diagnosis, or treatment. Aurora Brown and Anastacia Tomson are not able to answer specific health questions about individual situations. Always seek the advice of your health provider with any questions you may have regarding your health care and health conditions. Never disregard professional medical advice or delay in seeking it because of something you have heard or seen on this podcast. If you think you need immediate assistance, please call your local emergency number or any mental health crisis hotline. Hello and welcome back to Intersectional Psychology, the podcast that explores psychology's role in promoting social justice. I'm your host, Aurora Brown. I'm a registered counsellor in Cape Town, South Africa. Thank you for being here. How are you and what is happening in your world? Today we are kicking off a multi-part series on the health of people who are trans and gender diverse, or TGD for short. Gender diversity has been part of the human story for as long as we've had stories to tell. One of the earliest recorded trans figures in history is the Roman Emperor Elagabalus, who lived nearly 2,000 years ago and is said to have asked to be called a woman and even sought gender-affirming surgery. And across cultures throughout history, there have been numerous examples of gender diversity and gender non-compliance even before that. But until very recently, most cisgender people didn't give trans lives much thought at all, unless they actually knew a trans person personally. Now, gender-affirming healthcare is a term that's on everyone's lips. And apparently, everybody has an opinion about it. But here's the real question. How many people actually know what gender-affirming healthcare really is? What does it entail? How does it impact the lives of trans people? And then there's the question that somehow always gets framed as the most important. How does it impact cis people? Spoiler alert, not nearly as much as they think. So, to help us separate fact from fear-mongering, I am deeply honored to host someone who is, quite frankly, one of the most qualified people in South Africa to speak on this topic. Dr. Anastacia Tomson is a medical doctor, an author, and a fierce advocate for LGBTQIA+ and human rights. She was the lead author of the inaugural, and still the most comprehensive, guideline for gender-affirming healthcare in South Africa. Her lived experience as a queer, transgender woman who transitioned within South Africa's healthcare system, combined with her years of clinical work supporting others on their own journeys, gives her a rare and invaluable perspective. Her work is driven by a deep well of compassion and a fierce commitment to justice. Anastacia, welcome to the podcast.
Hi, it's my pleasure and privilege to have this conversation with you today, Aurora.
About the work of Dr. Anastacia Tomson. What can we know about you and your work?
I kind of hate talking about myself, and listening to the intro that you gave a few minutes ago, that just sounds to me like, wow, those are some big shoes to fill, and I wonder who that person is. So I don't always feel like that, Anastacia. But to put it in very simple and I'm going to try humble terms, I am a primary care provider, a GP, working in a remote fishing village outside of Cape Town that some of your listeners might have heard of. It's called Sea Point. And I treat LGBTQIA plus patients. I mean, I treat everyone, but I certainly have a special interest in treating LGBTQIA plus patients. I provide a lot of gender affirming healthcare services and manage the hormone therapy for a lot of trans folk. And in addition to that, I do a bunch of work with, let me say, patients who've experienced medical trauma over their tricky health conditions like fibromyalgia or POTS or connective tissue disease or et cetera, et cetera, et cetera. The kind of conditions where you go to the doctor and they don't believe that you have pain, or they look at the labs and say that you're fine, or, really where they just tell you, oh, go lose weight kind of thing. And that will solve all your problems. So those are the kind of things that I do. And then in addition to that, I do the occasional bit of activism, which whether or not I don't know if it's opt in or opt out at this point. We can have another conversation about consent sometime down the line. And I do a bit of teaching with medical students at UCT.
Thank you. I think I would have loved to be one of your students. I've attended some of your talks, and you have a wonderful sense of humor and a talent for making complicated subjects seem very clear and simple. How did you come to be involved in this work? How did you come to serve this community?
Accidentally, I was working in I was working in clinical research elsewhere in Cape Town. It was the first job that I took when we moved to Cape Town. It was actually the reason that we moved to Cape Town, my wife and I. So I was working in clinical research, and the company that I was working with landed on some difficult times, and I resigned and looked for some primary care work in the neighborhood that we at that point lived in, which was Sea Point. And I found a practice who was looking for another doctor to come on board, and I did so. And at that point, moving forward, since the beginning, I have learned through my own medical trauma that it's very difficult to rely on other people to manage my own hormone therapy. I did everything by the book. Initially, I have the scars from that. Those wounds still hurt me and make it difficult to seek my own health care. And I learned from those experiences now almost a decade ago that if I want to be cared for in the best possible way, I've got to do it myself. So I had the knowledge, or at least I had I'd built up the experiential sort of, yeah, education, the learn it by doing it sort of thing, and learn it by living it. And I also have always had that moment of reflection where I think, well, if I struggle like this as someone who has an actual medical degree, then what about the people who don't? Which in this country happens to be the majority of trans people who aren't walking around with medical degrees and prescribing rights. And I thought, well, that must be a pretty shit experience. So, sorry, am I allowed to swear? Okay, great. Got the thumbs up. So I thought that must be a pretty shitty experience. And I started offering these services because, I mean, no one else would. And it was just part of what I do. It was a much smaller part of what I do. I would say that by now, sort of 5 years later, 5 and a bit years later, the kind of specialized work or the niche work that I've told you about occupies about 85% of my clinical time. So certainly it's grown. And yeah, that's sort of I didn't set out and say, oh, I'm going to be the hormone doctor. It just kind of happened that way.
The real values underpinning gender-affirming healthcare. Now, the reason we are here today are the guidelines around gender-affirming healthcare. The South African HIV Clinician Society's Gender Affirming Healthcare Guideline, which was published in 2021, is the gold standard for gender affirming healthcare in South Africa. And it is the most comprehensive and evidence-based set of guidelines for trans healthcare. This guideline has been endorsed by a variety of professional and civil society organizations, including the Professional Association for Transgender Health South Africa, the Psychological Society of South Africa, the Wits Reproductive Health and HIV Institute, the University of Pretoria's Center for Sexualities, AIDS and Gender, Gender Dynamics, Triangle Project, and Be True to Me. You were the lead author of these guidelines, so I can't think of anyone better to talk about gender-affirming healthcare. Now, I believe the guideline was informed by the World Professional Association of Transgender Health Guidelines, but also adapted and decolonized for the South African context.
WPATH and their guidelines have been around for a long time. It's called Standards of Care. It dates back at some point before it was called WPATH. It was called the Harry Benjamin Institute for I don't even want to go there. But, you know, there has always been some clinical guideline for the management of trans folk to whatever extent. The problem is that these guidelines are developed in and for the global north, and trying to adapt them to sociocultural situations that are very different to that isn't always easy. You know, they'll talk about medications and treatments and tests and investigations and things that we just don't have. They have resources to their healthcare system that we just don't have. And we need to find solutions that make sense in this context. You know, you can't scale it in that sense because it's apples and oranges. So in developing the guidelines, we drew on a wealth of published scientific evidence, not just the WPATH guidelines, but we really did a very, 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 very comprehensive literature review to inform a lot of what we were suggesting in the guidelines. And throughout that process, we understood that localizing this and giving ownership to this community here in South Africa for whom we're writing this, and recognizing that, you know, probably it will be adapted or have some relevance or be drawn on elsewhere in Africa, you know, particularly in our neighboring countries. But we had that in mind, and we really tried to involve firstly a multidisciplinary team. So it wasn't just doctors or endocrinologists or psychiatrists, but we really tried to bring in people from a variety of different professions. You know, we had psychologists, we had dietitians, we had speech therapists weighing in on all of this. But we also looked at social policy and institutional policy, what happens in hospitals, what happens in prisons, what happens in clinics in terms of handling all of this. So we tried to take this kind of holistic view, and by assembling as diverse as we could a team of authors, and also recognizing that, this guideline was not ever intended to be the final gospel truth on gender affirming care. It was intended to be a first step, and knowing that things will change and that there will be, ideally, there will be new iterations, just like there are with the standards of care, that this was us trying to do right by the community in as many ways as we possibly could. And that was really important to us.
And yet, despite all of this evidence and all of the many years of clinical trials and research reports, the gender-affirming approach is still criticized by some as quote-unquote gender ideology. What are the values that really underpin this guideline?
I think the primary value is just respect for individual autonomy. We speak about in the guidelines, we say what are the indications for gender affirming hormone therapy, and number one is that you need to want the treatment. Number two is that you have gender incongruence. And number three is that you are capable of making a decision. So the entire power of decision making, as it should be in healthcare, rests with the individual who's accessing services. Our job isn't to make the decision on anyone's behalf. I can't say, yes, no, here's your hormones, you don't get hormones, you must have hormones. I don't get to do that. I have to use my knowledge, training, expertise, experience, skills in order to take the encyclopedic knowledge that I have around the human body and pharmacology and physiology and all of that, and pick out the little bits that relate to gender affirming hormone therapy and present them to, I use patient, to present them to the patient in a way that they can understand and that they can interpret, so that they can make a decision that is the best decision for them at that point in time. So the value for me that underpins, and I mean, you can go read the guidelines, they're open access, they're peer reviewed, but they are open access, and you can go read in the preamble some of the values that we as a team have said underpin the guidelines, and we do stick to them. I think for me, the most important thing was always going to be respect for autonomy. Everything that we've done is informed by an approach consistent with medical ethics, which is something else that I've published on in the past. So we continue to do that, and as is ethical, and as is in HPCSA, and as we are all taught, we should be working on an informed consent basis where people are permitted to have agency over their own bodies. And as you can imagine, not even imagine, but as you well know, in 2025, in the climate that we live in, even in the global north, or maybe even more so in the global north, this concept is becoming very, very politicized.
The truth about the access to gender-affirming healthcare. Now, before we dive into what gender-affirming healthcare actually comprises, let's talk about how someone would access gender-affirming healthcare. What is the process for an adult to follow before they can begin receiving gender-affirming healthcare?
So obviously that process is going to differ depending on where you are and on where you're accessing your services. So, I speak about where you are in terms of geography and where you're accessing services in terms of public versus private, and also at which level, is it primary, is it secondary, is it tertiary, etc. We, our guidelines and international guidelines are promoting the idea that gender affirming care should be available at a primary care level, that it doesn't require necessarily specialist initiation or intervention. It isn't yet easily accessible in the public sector in South Africa at a primary care level, especially now that a lot of the NGO public sector partnership clinics that were providing the service at primary care are no longer funded. So that does become a little bit tricky. At this point, a patient would have to present to their primary care provider and request a referral to the transgender clinic, for example, at Groote. This process will look different depending on where in South Africa you are. And in some areas like Limpopo, or this might be almost impossible. So it's very, very difficult potentially. It does get a little technically easier in the private sector if you are able to see a provider who is informed and knowledgeable about the provision of gender affirming care, or who is willing to learn and who's willing to prescribe the treatment for you. Then you would be able to make an appointment with that person. Ideally, this is what would happen if you were seeing me. That person would probably give you the information I would give you the information ahead of time to read up a little bit about the hormones. This would be information that I have personally sourced and vetted and that I will vouch for as being accurate. There's great information on the internet and there's also not so great information on the internet. So I would give you that ahead of time. Some patients would want to do their baseline laboratory investigations ahead of time. So maybe you go and do some blood tests. You would sit with me and we would go through what are your options? What does it look like? What are the pros, the cons, the risks, the benefits, the side effects, the consequences, the costs, etc. We go through all of it together. You'd have ample opportunity to ask questions. We would do a physical examination for you. And then we would collaborate in terms of the decision making on what is the route forward. Are you starting on hormone therapy? When are you starting on hormone therapy? What kind of hormone therapy are you starting on? So that's kind of what the process would look like in private, or in an ideal world, that is just what the process would look like, I think.
Thank you. Gender Inclusive Language 101. The guideline includes some very useful tips on gender inclusive language for practitioners to use when taking a sexual history. But I also think many of these tips would be helpful to every person listening to this who doesn't regularly interact with genderqueer folks. Which of these tips would you like to share here?
So I think it starts with, like, let's not make assumptions about what kind of people are in what relationships with what other kind of people and what kind of intercourse that they're having. So, it's language like partner instead of boyfriend, girlfriend, husband, wife, etc. I think it's also important to recognize that people might have multiple partners and that those partners could be regular partners or they could be sporadic partners. Just making space for people who are potentially polyamorous. I think it's important for us to find language that is disarmed in terms of referring to anatomy and body parts. And I think the best way to do this is just to have a conversation, either with the patient or with your partner, depending on whether you are a clinician or someone who's just getting some tonight, to find out, how would you like me to refer to this? Is there any language that you would prefer me to avoid? Or, a lot of it is just, let's not make assumptions. So, again, let's not lean into like the heteronormativity, but let's also just recognize that I can't know what's good and right for you unless I ask you. And I think maybe here's the number one tip is really just this, is don't be afraid to talk about it. We all are indoctrinated with this ideology that sexuality is a taboo and that we're not allowed to talk about it. And I've discovered one thing is that if you do talk about it, the world doesn't end and things are actually better for it. So, maybe that's the tip, is just practice talking about it. Go look in the mirror and have the conversation with yourself first.
Non-medical gender-affirming practices. You mentioned that there is a lot of misinformation about HIV and TGD people out there. There's also a lot of misinformation and disinformation, even in the media, about other aspects of gender-affirming healthcare, like hormone therapy and surgery. But there are actually also many non-medical gender-affirming practices that many TGD people start with before or even instead of hormonal or surgical transition. Could you tell us a bit more about these non-medical gender-affirming practices?
Yeah, I can. And I can tell you that a lot of people start with them long before medical or surgical intervention. I can tell you that some people start with them long afterwards, and some people start with them at the same time, and some people never do them. And the reason I'm saying all of this is just to reinforce and reiterate the idea that no two transitions look alike. The roadmap doesn't exist. So, I want to say it's different for everyone, but it actually just doesn't exist. And no singular transition is more or less valid than another one for what it does contain or doesn't contain or when it contains it. And it's for this reason that I refrain from using language like full transition. Even if we're talking about hormone therapy doses, we don't talk about a full dose, because that implies that someone who's on a low dose or someone who's microdosing is somehow less than. So I really don't want to do that. And, it just comes to mind when we say this. But transition can be so many different things. And, we can divide it up. Certainly, there are medical interventions, there are surgical interventions, but people can transition legally by updating their documents. People can transition socially by changing the way that they dress or using a different name or pronouns. People can pursue things like laser hair removal or electrolysis or voice training or bodybuilding. Each and every one of these can be gender affirming. And sometimes it is breaking the rules that are associated with gender that is actually gender affirming. So there are so many different ways that people might affirm their gender. And for some people, it might be binding, putting on a thick or elastic garment that flattens breast tissue to give the appearance of a more masculine chest. Or it might be tucking, where the external genitalia are folded up in such a way as to render them inconspicuous in even very revealing clothing or swimwear. But not everyone is going to do this. Not everyone should have to do this. There shouldn't be a responsibility on anyone to do this. But really, what I'm just trying to illustrate is that, this is a kaleidoscope. I mean, what I find gender affirming and what you find gender affirming could be very different. So we need to really take a much broader look at what gender affirmation is. Cisgender people do it too, I mean, cisgender men use testosterone, or they have treatment for alopecia, or, cisgender women who have augmentation mammoplasties or face. That's all gender affirmation, because we see these things through a gendered lens. So, the idea that we could reduce it into these like medical minutiae, when the entire concept of gender affirmation is actually rooted in social structure. And I'm not going to say gender is a social construct because things are much more nuanced than that. And please, let's not go there. But, to realize that like makeup, for example, is inherently not a gendered item, but we insist on seeing it in a gendered way. So recognizing that, I think the framework of what constitutes gender affirmation and what practices are gender affirming can be very, very different for everyone. And this is why reducing or minimalizing this lens that we consider care, and I'm not going to say healthcare, but I'm going to say care for trans and gender diverse people to this narrow focus of hormones and surgery, like that really isn't enough. We should welcome at the clinic, we should welcome people to use the bathroom or the restroom with which they identify, but we should also provide a neutral space for people who aren't comfortable in either of those spaces. And it doesn't mean now you have the men's room, the women's room, and the trances room that all of the trances must go to. It's not like that. But it's really about just figuring out what are the things that are acting actively to dismantle affirmation, and how do we deal with that? So, I've given you a very broad and ethereal answer to this question, but I think it almost necessitates that.
Please excuse me interrupting my own podcast. I'm just here to say that I will never include third-party ads on intersectional psychology, which is great because it means that you can be sure all the mental health information and content shared here is free from corporate influence and bias. However, it also means that this podcast will only be made possible by support from you, the listener. So if you enjoy this podcast or find value in it, please consider joining my Patreon, or Matreon rather, for as little as $3 per month. Your contributions will be used to improve this podcast, to cover the production costs to research, write, record, and edit each episode, and to host our guests. In return, you'll get exclusive Matreon benefits like bonus episodes, additional guided mindfulness recordings, early access to new episodes, extended episodes and outtakes, group discussions, and more. So just go to patreon.com and search for Intersectional Psychology. Thanks, and back to Intersectional Psychology. Truth about hormone therapy. Now we get to one of the contentious areas of gender-affirming healthcare, hormone therapy. So to start with, what should we know about HT in general?
What you should know about hormone therapy is that all human bodies have, at a baseline, some estrogen and some testosterone in varying degrees, but these are both molecules, substances, let's stick with molecules, that are intrinsic to the human body. They're not foreign, they're not outside elements, they're not these synthetic, dangerous chemicals that people might make them out to be, and that many of the drugs that we use to treat other conditions actually are. We are tinkering with the balance between estrogen and testosterone, but we're doing so using those exact same molecules and hormones that your body already produces. And then the other thing to bear in mind is just that we are not trying to do anything that is beyond physiological limits. So, the body is capable and programmed to and is happy in certain ranges with these hormones. And this is what we're trying to do with gender affirming hormone therapy. So if you're going on testosterone therapy, I'm not trying to give you Arnold Schwarzenegger doses of testosterone. I'm trying to give you physiological doses of testosterone.
When is hormone therapy prescribed and when isn't it?
When is hormone therapy prescribed? When someone wants hormone therapy, when they are gender incongruent, and when they are capable of giving consent. Sorry, that's only three things. But that is when hormone therapy is prescribed. There are very, very, very few of what we would call absolute contraindications to hormone therapy, cases where I absolutely cannot give hormone therapy. And that would be things like if someone has a cancer that is sensitive to one of the hormones, like an estrogen sensitive cancer. If estrogen is the growth factor, I'm of course not going to give that person estrogen. If it's someone who's had a venous thromboembolism or who has a familial clotting disease, then that could be an absolute contraindication. But other than that, we have relative contraindications. Areas where we have to exercise a little extra caution. Not that we don't exercise the utmost of caution anyway, which we do. And then we have coexisting conditions that need to be managed alongside. So like high blood pressure doesn't mean you can't have hormone therapy until you get below a certain measurement, but it does mean that I'm going to manage it at the same time.
Feminizing and masculinizing hormone therapy is obviously quite different and has different effects. What should we know about feminizing hormone therapy?
Feminizing hormone therapy, the specifics can be a little bit different depending on the case, but the backbone of it is estrogen. And what we're trying to do with the administration of estrogen is to promote the development of what we would call female secondary sexual characteristics. So things like the growth of breast tissue, things like body fat distribution, things like changing the texture and the oiliness of skin, things like promoting growth of scalp hair. These are the sort of things that we would expect from feminizing hormone therapy.
And how does masculinizing hormone therapy work?
Masculinizing hormone therapy, the backbone in this case would be testosterone, and we would be promoting virilization, which is the increase in muscle mass. It would make the skin oilier. We would see growth of facial hair. We would see thicker, coarser body hair. We would see probably an increase in libido. We would see an increase in sort of metabolic rate and that sort of thing. We would also see what we call bottom growth or hypertrophy of the clitoris. And in some instances, we would see the cessation, i.e. it would stop cyclical bleeding.
Now, if someone has already gone through endogenous puberty, there are some effects of that puberty that can't be reversed through hormone therapy. What are some of the impacts of puberty that hormone therapy can't change?
What's important to understand here is that hormones, sex hormones, estrogen and testosterone, have two kinds of effects. They have effects that are reversible and effects that are irreversible. And this is true whether we speak of exogenous hormones, that means the ones that you buy in the bottle, or endogenous hormones, that means the ones that come out of your body. All of them have both of these kinds of effects. Testosterone, for example, has a lot more irreversible effects than estrogen does. And if someone went through puberty and they were exposed to these high levels of testosterone, they would have developed some of these irreversible effects of testosterone, such as the growth of facial hair, such as the thickening of the vocal folds, which causes someone's voice to drop, potentially androgenic alopecia, male pattern baldness, could be irreversible if it's persisted for long enough. That's the effect of testosterone and its metabolites on the hair follicles themselves. So these are irreversible effects that we talk about, and someone who's been exposed to endogenous hormones will experience those. Then, on the other hand, if we speak about estrogen, what are irreversible effects of estrogen? Well, that would be the development of breast tissues. So, I'm talking here about structural breast tissue, glands, and ducts. If there's fat in breast, which there is, some of that might distribute away and they might get smaller. But the growth of breast tissue. So, if you've gone through a puberty and you've developed D-cup breasts, and those aren't going to go away unless something else is done. And then, of course, we just have to consider, when it comes to things like skeletal growth and dimensions, so the hormones do have an effect ultimately on how you grow and for how long you will grow and in what ways you will grow in the shape of bones and things like that, which are they're irreversible not by virtue of the hormones, but by virtue of time.
So, would it be fair to say that as a TGD person starting hormone therapy, you're basically experiencing a second puberty, and all of those changes that are irreversible in endogenous puberty would then also be irreversible after taking hormone therapy?
Yeah, I think it would be unfair to say it, but 100% true. You are going through a second puberty. And if it was difficult the first time, try doing it when you understand what's going on and how the world around you works. And you've actually got that sort of lived experience and that wisdom, to then go through a period where your skin becomes oily and pimply and your voice is breaking and so on. But yeah, the irreversible changes would occur in a second puberty as well. And that's what we expect to see in people who are going on exogenous hormone therapy.
The truth about gender-affirming surgery. And now let's talk about surgery. Before we get into specifics, what background information should we know about gender-affirming surgery?
I think what we should know is that this is often a facet of trans experience that the cisgender majority wants to focus on and zoom in on, and it attracts all kinds of just attention, and it's almost seen as, this is what trans identity is about, is the sex change operation. And what I think is very important to realize is just that of trans people who want gender affirming surgery, which is not all of them and doesn't have to be all of them, and no trans person is less valid because they don't want surgery or they don't get surgery, it is a fraction of people who will actually have access to those procedures. And so much of trans lived experience is non-surgical. Not to say that surgery can't play a role in it, but just that it's non-surgical, and even to say that surgical experience doesn't occur in isolation because there's so much that goes on around it that is non-surgical. So to get lost in that conversation is very unhelpful. If you want to understand trans people better, to have another pin on your ally flag, then don't start by reading up on surgery. It's not going to get you there. And certainly don't go around and ask your token trans friends about the surgeries that they've had or the surgeries that they've wanted. There is so much more to this. The surgeries can be very interesting, in terms of like anatomy and technique and so on. Particularly if you do have an interest in things surgical, I find it very fascinating to understand what procedures are being done and how they're being done and what new techniques are being developed. But that's an interest that's born out of my sort of fascination with surgery in general, and not out of my obsession with what's inside people's pants.
Thanks. As you say, a fraction of trans people who want surgery actually have access to it, especially here in South Africa. I think in the Western Cape there are only 1 or 2 gender affirming surgeries performed per year in the public sector. And I know that trans people who inquire about it are told the waiting list for gender affirming surgery here is about 15 years in the public health system. So it's really not everyone who is going to have such surgeries. Not everyone wants it, and even fewer people have access to it. Now, when is surgery prescribed and when isn't it?
The first thing about the surgery about surgical intervention is that you need to want it. We shouldn't be, and I'm not going to name names, but I believe that there are certain gender clinics that have been in operation in South Africa that had patients sign a contract before they went on hormone therapy saying that they will at a later date have surgery. We don't do that. We shouldn't do that. It's an individual choice. It can affect so many different things in so many different ways. There's healing time, there's complications, there's all sorts of things that go into it. So who gets surgery? Someone who wants surgery, someone who is capable of making that decision. There is often going to be a requirement for at least an interaction with a mental health care provider who's of suitable qualification to ensure that a patient is competent to make the decision. So there's still that little bit of gatekeeping involved. And I think it's also important to realize that, surgery isn't enough on its own. I have patients coming in through my door who had gender affirming surgery 25 years ago. And since then, no one so much as prescribed a hormone for these people. They've been walking around with zero testosterone, zero estrogen, increasing their risk for osteoporosis, for fractures, for heart disease, for depression, for all kinds of things. So, it's not like you put people on this assembly line and you do surgery and then off they go. Further to that, it's got to be people who we always consider surgical risk and the benefit. And, someone who is a good candidate for surgery will be someone who's what we term anesthetic risk or risk of complications related to other medical conditions is as low as possible, that if there are other conditions that they've been optimized, that this is someone who's going to be able to adequately recover and to go through all of the procedures that are associated with that. Sometimes there's like a little bit of maintenance that needs to be done. And, it's not something to be taken lightly. But if someone expresses this persistent desire for a certain procedure, and then we've had the conversation with them, the informed consent, we've managed their expectations, surgery is never going to be a silver bullet. It could be that you have intense dysphoria over certain parts of your anatomy, and you will never have that dysphoria adequately relieved without surgery, but you will not necessarily just need the surgery in order to feel better. So, it's in that case, it could be necessary, but not sufficient, if that makes some sense. So these are the considerations around, we don't prescribe surgery. We collaborate with people on a decision, and then we try to get them access to the interventions that they want or need, and to do so in a way that is safe and responsible and scientifically sound.
Future for everyone. As we wind up this episode, would you like to share what is on the horizon for you?
Not really anything that I can very directly plug, just to say that there are some exciting things happening in terms of rolling out at least training on gender affirming healthcare at the primary care level. I don't know how much detail I'm allowed to give on it, so I'm not going to. And then to say just on an individual, or not an individual level, but at least part of on the level of the team and the practice that I run, is just that we are looking at some ways to actually do some research into the role of narrative agency in healthcare, which I think is very important for both patients and for providers. and that there's a whole lot of interesting and intersectional conversation to be had around that, and the sort of colonialism that remains inherent and the patriarchy that remains inherent in medicine, and how we dismantle that through voice, whether it is spoken voice or written voice, etc. So I find that to be intriguing, and if I can get funding to do the research, then certainly I'll be blabbing about it a lot more.
That sounds really exciting. And seeing as you didn't mention it yourself, I'll just plug your book. It is for sale all over. I know Exclusive Books have it here in South Africa, and it is also available internationally. Just search for Always Anastacia by Anastacia Tomson. I loved reading it. I really enjoyed reading a positive representation of a trans person in South Africa, and it is written with your usual eloquence and sense of humor.
Thank you. The book, I often forget to mention it because it's 9 years old. It's almost going to be able to go to school by itself. So I forget that it's a thing, and it just keeps coming back, which I suppose is a good thing. But it also reminds me of that I probably need to sit down and write another one, and I don't know on whose time and on whose coin I'm going to do that. So we're still trying to figure that one out.
Where can listeners go to find out more about you and your work?
For better or worse, I'm infinitely Googleable. The only trapdoor there is that you have to spell my surname correctly. It doesn't have an H and it doesn't have a P. You'll also find me all over social media under the handle Anaphylaxis. That's got a US at the end, not an IS at the end. Again, it is a very deliberate and intended misspelling. So it's not really a misspelling, but you'll find me all over social, and you can also read more about the work that we do at the practice at myfamily.gp, if you so wish.
Anastacia, thank you so much for your time and your insight and your extraordinary contributions to trans healthcare in South Africa. You've not only helped demystify what gender-affirming healthcare actually is, you've also reminded us that healthcare, at its heart, should be about care. For anyone listening who thought gender-affirming healthcare was a niche issue or some kind of political hot potato, today made it clear. It's healthcare. Full stop. It's evidence-based, it is life-saving, and when it's done right, it can be profoundly affirming, not just of gender, but of humanity. And if you're still wondering how it affects cis people, maybe it's this. The more we build systems that honor everyone's dignity, the better they work for all of us. This was just the first episode in our series on the health of trans and gender diverse people. In our next installment, we'll be speaking to a mental health professional about what an affirming therapeutic relationship really looks like, and how to tell the difference between support and subtle sabotage. Until then, stay curious, stay compassionate, and please don't believe everything you hear in the WhatsApp groups. Thank you for listening to Intersectional Psychology. Please follow or subscribe to the podcast to get every episode. If you enjoyed this episode, please rate and review Intersectional Psychology in your preferred app. It really helps other people find the podcast. This episode of Intersectional Psychology was researched, written, recorded, and edited by me, Aurora Brown. For a transcript of this episode, please see the link in the show notes on your podcast app or go to intersectionalpsychology.com. You can also check the website or the show notes for a full list of references for this episode. A video of this episode with closed captions is available on youtube.com/@intersectional psychology. To support this podcast and get access to bonus content, including additional episodes and interviews, as well as more guided mindfulness sessions, please go to patreon.com/intersectional psychology. You can also chat with me on Blue Sky at intersectpsych.bsky.social and Instagram, Facebook, or TikTok at intersectional psychology. But mostly Blue Sky. Aurora Brown and Intersectional Psychology are committed to the Sight Black Women praxis. All episodes of Intersectional Psychology are for educational purposes only and are not intended to be a substitute for professional mental health advice, diagnosis, or treatment. I, Aurora Brown, am not able to answer specific questions about individual situations. Always seek the advice of your health provider with any questions you may have regarding a mental health condition. Never disregard professional medical advice or delay in seeking it because of something you have heard or seen on this podcast. If you think you need immediate assistance, please call your local emergency number or any mental health crisis hotline. Everyone deserves good mental health.